Hi all, greetings from Christian Medical College, Vellore, Tamil Nadu. I am Dr. Satish, Professor in Cardiothoracic Anesthesia, and I am also head of the unit for the Cardiothoracic Anesthesia in CMC Vellore. I am going to talk about troubleshooting in one lung ventilation. You can do thoracic or cardiac procedure like minimally invasive cardiac surgeries with the one lung ventilation. Dealt with some problems with the one lung ventilation, how to troubleshoot it. Let us see what are the various difficulties in one lung ventilation. First is insertion challenges. As a beginner, even for the experienced people, sometimes they find difficulty how to come across that. Next is isolation difficulties, and other commonest problems are hypoxia. What are the causes of hypoxia? And important problems during one lung ventilation, malposition of the DLT or bronchial blockers, and suddenly you will come across, you can encounter high peak airway pressures, or the surgeon will be shouting that lung fails to collapse during the surgery. Then how are you going to deal all these problems? Let us see one by one. First, we should know which are the patient give trouble. As for the intubation, like any other condition for upper airway intubation, like normal endotracheal tube, like short neck, prominent upper incisors, limited cervical mobility, limited jaw opening, or previous radiotherapy or tumors, you will get difficulty in intubation. But what are the lower airway problems which give trouble for one lung isolation? Existing tracheostomy, distorted anatomy of the trachea or bronchus, compression of the entrance of left main bronchus by a tumor, or descending thoracic aortic aneurysm, previous lobectomy, or congenital conditions like tracheoesophageal fistula can give trouble for isolating the lung. When you put a DLT, sometimes if you don't take precaution, you may land up in trouble, like proper curvature of the DLT. Let me show in the next slides how to do a proper curvature and also proper stiletting of the tube. And also when you do intubation with the DLT, the bronchial cuff will surpass the tracheal vocal cords, but you should be aware that tracheal cuff is still not gone in and it is at the level of the teeth, and if you manipulate the bronchial cuff up and down, it can cause tracheal cuff injury at the level of teeth. I will show a video after this. And how will you use tube exchange if you are difficult to pass the DLT? And whether video laryngoscope has totally replaced normal conventional laryngoscope for DLT placement, let us see. This is a picture I want to highlight the curvature. This is the standard one which comes with the package. If you do this, sometimes it may find difficult to insert. If you curve like any other endotracheal tube, then it will be little more